Hi, my name is Dr. Warrick Bishop, and I'm absolutely delighted you've joined me on my podcast and videocast station. But I'm even more delighted today. I have a colleague, Dr. Fiona Foo, who's a cardiologist who has been on the podcast before. And the reason I'm super pleased that she's joining us is from her previous podcasts, which were on climate and environment. I had remarkable feedback. I had people reaching out and letting me know how informative, how organized, and clearly how clever she was in the space. So I'm going to introduce Fiona. How are you?
Yeah, great.
And
That,
delightful to catch up with you, and I really do appreciate your time. Fiona, for those listening, is busy as a fly at a barbecue. She's got so many fingers and so few pies, or so many pies and so few fingers. She's so busy with interventional work, with prevention work. She works at the Sydney Cardiologist Group. She does on call. She has all sorts of interests, and we're not going to dive into all of those today. Oh, and while I think of it, for those who may have missed Fiona's previous podcasts, they are number 348 and 349 of my podcast series, 348 and 349, and we're talking about climate and cardiovascular disease. Really interesting. Anyway, how are you today, Fiona?
yeah, fantastic.
So We we generally one of the really nice things about your practice is you've oriented it towards some of the issues that we see with female patients, women patients, and today we've selected heart failure with preserved ejection fraction as a topic that I think is a really important topic broadly in the cardiovascular community, but also really important for women.
Mm.
Now, for those listening, can you explain what heart failure with preserved ejection fraction is in layman terms?
So, as your listeners may know, so we've got heart failure, which I guess people think of it as the heart not pumping well. And so that's mainly heart failure with reduced ejection fraction. So the heart not contracting well and pumping the blood out. Whereas heart failure with preserved ejection fraction is where the heart doesn't relax well. So it's that kind of stiff heart that it doesn't relax well, but it presents very similarly. So you get similar heart failure symptoms. So the main symptom is shortness of breath, and they could get fluid on their lungs, and but it's, or they can't lie down flat, but they get similar symptoms to that heart failure with reduced ejection fraction where they don't pump well, but this one is where they don't relax well.
So, for those who like a visual, and I'm a bit of a visual person, if I can offer this, Fiona, I often think of a squeeze box or a piano accordion. And if you can't squeeze it very well, so as you try to squeeze it in, you've got weak power or the squeeze box doesn't work very well, then it doesn't squeeze well. That's heart failure with reduced ejection fraction or reduced squeezing power. But if you've got a squeeze box that's really sticky and old and you can't pull it apart, that's heart failure with um, preserved ejection fraction. So it's sticky, it doesn't relax very well. So maybe that's a nice visual for people who are listening in.
The other thing you mentioned there, which is age, is actually quite important because so this heart failure with preserved ejection fraction actually increases with age, is actually one of the biggest risk factors. And we know that we know that the prevalence and incidence, so the amount of heart failure with preserved ejection fraction is actually increasing, and it's increasing relative to that of reduced ejection fraction. And that's partly because of our aging population, but also due to some of the other, I guess, risk factors for heart failure with preserved ejection fraction, including hypertension and obesity, and diabetes, and atrial fibrillation. So these are all risk factors that increase heart failure with preserved ejection fraction, and that increases with age. And so there we're seeing this rise of this heart failure with preserved ejection fraction in the general population.
So for to bring our listeners in on a bit of medical jargon and to save you the mouthful of heart failure with preserved ejection fraction, which is a huge mouthful. Why don't we use the terminology that cardiologists use, which is an acronym: heart failure, HF, with preserved P, ejection fraction, HFpEF.
Yeah.
So why don't we call it HFpEF? That'll be
Yes, thank you.
making our audience so much smarter and in the know, and it'll make your you won't get tongue tied on that HFpEF. So look, age obviously is one of the really important um, risk factors, but what are some of the others? And women are important in this cohort as well, aren't they, Fiona?
Yeah, so well, let's talk about women first. So essentially women outnumber men by about 2 to 1. And it increases particularly when they get older with post-menopause. So that older female is one of those bigger groups. They talk about different groups of HFpEF. So that kind of think about that older female, often who has hypertension. They are a big group of people with HFpEF. And then there's other groups. So there's another big group of HFpEF patients that are this kind of metabolic, inflammatory, overweight, and obese group. And they actually have quite a high risk of heart failure, hospitalizations, and more issues. And then some of the other risk factors. So the biggest risk factors that we're going to go through are things such as, so age was one of them, but then high blood pressure. Obesity and diabetes that I've mentioned. Atrial fibrillation is a contributor. Chronic obstructive pulmonary disease and lung disease. And then chronic kidney disease, I think one are some of the ones that we'll talk about. So these, and then there's also some heart artery disease, but that's more non-obstructive heart artery disease that we'd mentioned previously with the females as well. Yeah.
So when we're thinking about a heart that's not relaxing very well, um, what are the sort of symptoms that someone might get from that? What obviously as we age, we get well, I'm a little bit older than I was 20 odd years ago, and I have to admit, I don't run quite as well. I get a tiny bit puffier than I used to, and I think it feels to me like it's normal aging. But for people who are getting older, how would they, what sort of signs, what sort of features might they, or symptoms might they notice as they're getting older, but potentially might be getting HFpEF? How does that work?
So I think it is hard to differentiate, whether you're getting short of breath from just being older and less fit. And so ultimately, we have to, it's like that constellation of symptoms. So main symptom is shortness of breath on exertion, but then you can present acutely with like shortness of breath if you're, when you lie down flat. Fluid on the legs is, like that accumulation of leg swelling is one of those symptoms. So those are the main things, but then to kind of diagnose it, you can have those symptoms, but then you also have signs of like fluid on your lungs or on a chest X-ray. And then one of the other important things that we can test for, mainly acutely, but I guess also chronically, is something called BNP, so an elevated level of BNP, which is a brain natriuretic peptide in the blood. So that goes up. Yeah.
So before we come, we'll talk a bit more about brain natriuretic peptide because it's a really fascinating space, I think. But before we do, one of the things you said is that when people lay down, they can get shortness of breath. And some people may be listening to that and thinking, that's a bit odd. Why would it be when you lay down that you get shortness of breath? Do you want to speak to that for a moment?
I also mentioned that apart from laying down flat, they wake up short of breath. So yeah. So that's mainly you can add more to this, but more mainly the fluid on your lungs, and all those kind of increased pressures in your heart. I think that just kind of cause you to be so short of breath that you cannot lay down flat to sleep.
So I've often thought of it myself, and correct me if I'm wrong, but as our hearts fail to work properly, HFpEF or heart failure, even with reduced ejection fraction, the body holds on to a bit of extra fluid. That extra fluid is the compensatory mechanism that's driven by the receptors in our body. So our receptors in our body were evolved 2 odd million years ago in our evolutionary ancestors, and they were all geared up so that if we got bitten by a saber-toothed tiger and we lost some blood, our body would hold on to fluid as well as possible so that we could re-establish that blood volume. Now, fast forward to current day and fast forward from our ancestors who would live to 20, 25 years of age to people who are living 60, 70, 80, 90 years of age. And what now happens is if the heart's not working well, because it's not delivering the pressures to those sensors in our body thinks, wow, maybe we're on the African plains, maybe we've lost a bit of blood because we got bitten by a saber-toothed tiger. Let's hold on to some of that fluid. And so the body holds on to more fluid. Unbeknownst to it, the body actually hasn't lost any fluid. So the consequence is more fluid in the body of someone with heart failure as they're standing around in the kitchen, doing their shopping, whatever it might be. A lot of that fluid moves with gravity, so to the dependent parts of the body. And so they may get engorgement in the legs. And you touched on swelling the legs. When those people lay down, that redistribution of fluid throughout the body almost equally, because gravity is equal when you're laying down flat, means that more fluid can roll into the lungs. And if more fluid rolls into the lungs can be quite stiff because there's more blood in the arteries and in the capillaries of the lungs, and stiff lungs make you short of breath. So that's a nice way to sort of think of
Great
it.
way.
So I think it's fascinating. And for those listening, it's just so cool because what we're really thinking about is an evolutionary adaptation sort of goes wrong as we get older in our modern society. So I think that's so cool, actually.
Yeah, no, and I think that waking up short of breath is and yeah, not being able to lie flat is a very, very sensitive and symptom of heart failure. One interesting other one in severe heart failure is actually bending over and getting short of breath, bending over.
Yep.
Which I never really thought about until someone actually pointed that out, that actually that is quite a severe symptom.
I will say, and this is a plug for me, but if anyone is after any more information, we cover some of these concepts in a lot of detail in Cardiac Failure Explained, which is one of the books I've written to help people understand their journey through heart-related issues. Now, back to brain natriuretic peptide, Fiona. Sorry to have jumped in there, but I love that sort of positional shortness of breath issue. So I just wanted to touch on it a bit more.
Yeah, I mean, I think with the brain natriuretic peptide, I think it's just, I guess, as your listeners, for your listeners, in terms of what it is. Essentially, it's something released in your blood that increases particularly with heart failure. So it's elevated if you go into both HFpEF, acute heart failure, or even in HFrEF as well. So, and then they can use it to guide management. But it's useful because, so you come into an emergency department or even see your GP with shortness of breath, and you can send that blood test, and it's very specific for being from your heart rather than being from your lungs. So then, if you have an elevated BNP, then it's more likely that you have heart failure rather than it being from your lungs, like that shortness of breath. So that's quite a good way of kind of, I guess, ruling in the diagnosis, as well as other things like having a chest X-ray that shows fluid on the lungs and things like that, as well as, the signs and symptoms.
You're quite right. And for those listening, what Fiona's just said there and the role of brain natriuretic peptide in trying to discern between shortness of breath from the lungs or from the heart, it's absolute gold because sometimes people are just really hard to assess. You can't be sure whether it's the lungs playing up or the heart playing up. And a very clear indicator on one of these tests can give you a really, really good idea. I'll add a little bit there on brain natriuretic peptide. There's a number of peptides, uh, atrial natriuretic peptide, brain natriuretic peptide. There's a number of peptides that are released by the heart when it's under strain. Now, these peptides actually have a role. You may have heard in the name natriuretic. That means they make you pee. So these hormones, these chemicals released by the heart actually take load off the heart and protect the heart when it realizes it's under strain, which is so cool. And what's really, really cool about that is some of the therapies that we've got for treating heart failure now act to reduce the body's breakdown of those chemicals so they float around even more and help with natriuresis, passing fluid, vasodilatation, opening up the arteries and taking pressure off the heart, reducing inflammation, and helping the heart return to its normal shape. So it's a really important space. These natriuretic peptides are so important in not just diagnosis, but we also tap into them in therapy. So they're super cool.
Yeah, and particularly that is in that heart failure with reduced ejection fraction, that the Entresto medication for that.
Yeah,
So,
100%.
yeah.
Super important. So we talked a bit about what heart failure, HFpEF can look like in terms of the heart being stiff. We've talked a bit about some of those symptoms.
So
We
you want
talked
to talk
about
about some risk factors? So
Well, I think we should talk about the risk factors, and we've talked about diagnosis a little, and we might get to the end of that. And because there's such a lot to talk about, we might come back for a part two, if it's all right with you, and cover management and then prevention strategies, or prevention strategies and management, something like that.
sure.
Okay. Um, so we've got, let's cover risk factors, and then we'll draw a line under it there and then come back.
Yeah. Okay. So as I said, age is one of the most important ones. Hypertension and obesity account for about 2/3 of HFpEF. So hypertension, particularly most patients, even up to 90% of patients with HFpEF have hypertension. So and if you look at when someone has high blood pressure, they get that very stiff heart. So that kind of adds to that impaired relaxation that comes with HFpEF. So it's very important to treat that. And particularly when we talk about females, high blood pressure is an even greater risk factor for HFpEF in females. Then if you talk about obesity, so obesity, again, nearly 80% of patients with HFpEF are either overweight or obese. So that's another big risk factor for HFpEF. And they've found that if you every increase, your increase in your BMI is associated with an increase in your risk of HFpEF. And again, getting back to females again, obesity is more common in women than men, particularly after menopause as well, and that increases their risk. So some of these risk factors explain why women have a greater risk of HFpEF after menopause, where all these hypertension and obesity, as well as diabetes, also increases. And then there's diabetes. So again, nearly 30 to 40% of patients with HFpEF have diabetes. Again, greater in women. So the diabetes increases the risk of heart failure more in women. So I guess with all those kind of traditional risk factors, they seem to affect women more, particularly after menopause, and increasing the risk of heart failure, but also of coronary artery disease. And then some of the other ones, so diabetes, and then we've got chronic kidney disease. So people with renal kidney problems, that can increase their risk, and that's quite a high risk, what we call phenotype. So very, they have worse outcomes if they have bad kidney problems with the HFpEF. Coronary artery disease is common. So you can get obstructive coronary artery disease, which often causes heart failure with reduced ejection fraction. If someone has a big heart attack, and it can cause that impaired heart function. But often in patients with HFpEF, they have non-obstructive coronary artery disease, and they have something called coronary microvascular dysfunction, which we talked about with the previous female and heart artery disease. So where you just get problems with the small vessels of the heart, and that's actually very common in patients with HFpEF, that coronary microvascular dysfunction, the problem with the small vessels of the heart. Other things, so atrial fibrillation, is actually one of the biggest problems, because that comes with age, obesity, high blood pressure, all of these kind of shared risk factors, and that increases the risk of developing HFpEF. So it's kind of what, I don't know, chicken or egg, which comes first? Yeah.
They're sort of linked, aren't they, really?
Yeah, correct. Yeah. And then other ones, COPD, sorry, chronic obstructive pulmonary disease I've talked about, and obstructive sleep apnea. So they're those kind of like lung issues as well as sleep apnea. And I guess with the lung issues, it comes back to that BNP, because some people do present with both. Like they're going to have heart failure, but they're also going to have like emphysema or bronchitis as well to cause their shortness of breath. And then the only thing before we finish, I'll just touch on, apart from with the women issue, so we've got those traditional risk factors that increase the risk, particularly after menopause, of heart failure of HFpEF. But then they've also got sex-specific risk factors, and the biggest one, I think, I just want your listeners to understand is some of the hypertensive disorder, like those pregnancy disorders. So hypertensive disorders of pregnancy, particularly because it increases your risk of further hypertension. But they have an increased risk of heart failure of HFpEF, as well as some other things like gestational diabetes, autoimmune disease, and some breast cancer. They can increase your risk of heart failure. Some mainly heart failure with reduced ejection fraction, but also heart failure like HFpEF as well.
I think touching on those gestational related cardiovascular issues really, really important. But I think also touching on people who've gone through chemotherapy, we do see that chemotherapeutic agents can have an impact on the heart function. And so an awareness of that is really important. So look, I think this is a great place to pause. I'm so excited because we can come back and do a part two. We've introduced the concept of HFpEF. Everyone who's listening knows what HFpEF is now, heart failure with preserved ejection fraction, not reduced ejection fraction. We've talked about what symptoms people may get. We've talked about some of the diagnosis, and we've talked about the risk factors. So I'd really like to come back and talk about how we manage it. And then I'd like to talk about some of the preventative strategies and what people really should be aware of. So for now, I'm going to say thanks so much, Fiona, for sharing. For those listening, as always, I'm super grateful that you bothered to listen. And I am really, really grateful when people offer feedback. So if you thought Fiona was fantastic again, please let me know, because otherwise we do this stuff in isolation. You think, are you making a difference? Are you helping people? So it's hugely satisfying and gratifying if people reach out and say, that was great, or I learned this. So please let me know. And if you do like it, share it. I know if you're one of Fiona's patients, there's a very good chance she will have directed you to this to have a listen so that you could get more information, because there's almost never enough time in a consulting session. So this is a great way to get more information and more depth. So been a pleasure sharing with you, Fiona. Look forward to coming back. And for those listening, I hope you live as well as possible for as long as possible. Take care and bye for now.